and make some decent money.
It is.
All right, so we're live, and I'm gonna do a screen share. So I see by the attendance, or at least a little bit better attendance tonight, that some of you guys actually took my email. I don't know if serious or to heart, but I do appreciate you guys showing up and coming. One thing I friggin' hate is sitting here talking to two people and expecting something to get done. So anyway, Marty and probably Greg and probably Regina and probably Sarah. There's protocol and a sheet right over there on the thing to grab one of those. First thing that I want to talk about again and again is post-run check sheet that we have. Maybe it should be renamed. Guys, this is there to help you because I want us keeping our own time. I really despise us using dispatcher time, and it'll help us keep mileage. I know that you guys aren't using it because whenever I work with somebody, they can't remember write down times and mileage. And it's one of those things that the more you use it, the more it'll become, just a habit to write it down. Your mileage is important, your times are important, and I think that we keep better times and mileage than dispatch. So here it is. I want you guys to take a look at it and make any suggestions. Look at it real quick, and I'm willing to listen for a minute. Any suggestions you have to make this easier to use, because I want you guys using it. So the backside, understand the backside is just there to help you out. And some people have been in higher call volume services, and they don't need the sample no PRST history. They have a good interviewing technique they already use. But if you don't, the backside is to help you guys out, okay? One thing, I'm doing an EMR class right now, and one thing I've tried to stress to them is if you use your sample no PQRST history, you will get enough information to run a good call, okay? Especially at the basic level. Now, paramedic, advanced. Okay. So it'll be on YouTube. You can just watch it anytime. So I'll show you whenever you get back. So back to what I was saying, the paramedics advanced, you guys are going to go beyond this. But at the basic level, I know that you guys get pretty nervous on some of the calls and on some of the scenes because you don't run enough calls. If you guys run through the sample no PQRST history, you'll have a lot of really good information to be able to relay to the facility. You'll have a lot less of a chance of leaving things out. But anyway, enough on that. The backside to help you guys out, I even put a radio template in there for you guys to call and report. I know that our hospital has requested that we call in reports because at times we don't. We're a minute away and they don't give them any time, but I've explained to them that we're a minute away. We don't have time. Sometimes it's just a quick, hey, we're coming a minute away would be enough. So, you guys see anything on that first page that maybe we could change to make it work better? You guys do understand if we fill this out and the state comes and inspects that we're covered. I know that our ambulance check covers us too, but on these other ambulances that we run.
Other door, please.
So you want us to fill it out and turn it in?
No. After every run, just fill it out.
It's just to help with our report.
Yeah, it's just to help with your report. If we make a folder for it, just to keep it, especially on unit 22, 20, and 21, if you run out of those.
They're actually on here.
Did you get mine? Oh, no, here. Thanks, Gina.
What?
You guys see anything on that?
Catch that. No, go. Catch it.
Anything? Bueller?
Which side are you talking about?
Which side are you talking about? Well, the back side with the sample and QRST history.
And you wanna start keeping that in the file?
Well, it's two-sided. I print them off all two-sided. Back side to help you guys out. That's how I print them off. They're like that. So on the back side, I mean, I haven't got a place for your initial set of vitals. Back in the day, whenever we were trying to get the flight numbers, there's a place for you guys write down flight numbers, a place for medication. You could do a kind of a short report on there, not even worry about the computer. There's some people that are really anal about their times. I am not one of those people. I'll use my monitor. I know that I did a medication shortly after this blood pressure. I put my medication in there. It's all relative, right? So I'm not, now Sabrina is one that she writes down everything.
And she's one of those that can find it later too. Which is totally nice.
Anyway, it's for you guys. The back side's for you guys. Front side is something that I want you using to keep your mileages and times. All right. Make sense? You all right now?
He needs page 1, page 2. That's what he can.
I'm gonna put front side.
You want me to put page 1, page 2? I mean, that's easy to do. So I do keep them on the clip. I put the clipboard in the front of the ambulance. Guys, rather than write it down on that little piece of paper, you guys write it down on. Everybody writes it down on a different piece of paper. Just write it down on that one on the clipboard. Keep that clipboard up there. It should have your other paperwork in there. And then just take it off the clipboard if you're gonna go use it in the back. So, I really want you guys to start using it. So. All right. So if there's no questions on that, let's move on. We have a subscription, and this pertains to probably you guys. I need to get you guys set up with an account to EMS Jane for training. I'm going to start using that more. And I've tried this before, and I always get sidetracked. I'm going to try to get on it again. I'm going to try to have an EMS Jane do that's going to relate to the topic that we sit here and talk about that night. And the other side of that is I'm going to try to have it relate to what National Registry and State requires to have the renewal. And you guys all know that has changed, right? You don't have to have a 48-hour refresher course anymore. You don't have to have a 30-hour National Registry hour. It's confusing. I wish I would have left it how it was. They're like, but you have less hours now. Yeah, but you made it very hard to do. Before we did a 48-hour refresher and then whatever hours we wanted. Well, now state has their requirements. So you have a TIMS that you have to have, which by the way, I did the trainer. So I could do I'll do the TIMS class in-house. For the state, you have 30 hours that are required by national. And I forget how many hours it is. It's on NRMT's website, how many hours you have to have to renew. But so I'll try to make our EMS, it's not EMS Jane either. They teamed up with somebody else. I'll try to make that training correlate to the training we're going to have that month. So I'll try to schedule at the beginning of the month so you guys have a whole month. When you're on shift, just do it real quick. You have a whole month to do it before the training. And then that month's training will be around that topic. Makes sense? So that I'm not sitting here trying to come up with friggin' topics to talk about. So I'm running out of ideas. So anyway, so that's coming. But what I do want to talk about tonight for our topic is cardiac calls and ACS, or acute coronary syndrome. The reason I want to talk about it is because I feel like we could do a better job at it. And I feel like you do a good job. Everybody has shot 12 leads here, right? How many people have you shot one yet? 12 leads? Okay. How many people have been able to transmit lately?
What?
Exactly.
I told you like 6 months ago.
Does Great Plains transmit?
Yeah, it goes right to their fax machine.
That they don't ever look at?
Well, there's.
Not my problem.
You can
I'm actually not concerned about the transmit, but whenever I do want to transmit, it drives me freaking insane when my phone's dead. So we got to figure out something. We need to make sure that our phone's plugged in, and I'm guilty too, guys. I'm not saying you guys. I'm guilty as well. As a matter of fact, I don't even know if there's a freaking charger in that ambulance.
Not that one.
So I got to figure out a charger, or find the charger that was in there. So we keep our phone charged up. and turn our phone turned on so that whenever we do try to transmit the 12 lead EKG because we have a STEMI and we're trying to tell somebody we have a STEMI and show them we have a STEMI, it'll transmit.
I'm fixing to throw your new computer on the floor and stomp on it twice.
No,
Sir.
there's nothing wrong with my new computer.
Well, then you come erase this time so I can put the correct one in.
You erase the content with the correct one. So anyway,
Yeah, give it to him.
ACS
Give it to him.
and acute coronary syndrome. There are a lot of calls that we could be running 12 lead EKGs on that we're not. And I will give a little leeway to the basics in Cheyenne that aren't running it. A little. Outside of Cheyenne, if you have any of the signs or symptoms, we're gonna look at the protocol in a minute. You need to do a 12 lead EKG. Now, Vicki, you're better at recognizing this than me. Are we always in this situation that we need to? And I should ask you after we go over this so you have a better idea. Do you feel like there's still times that we could be running 12 leads that we're not? Okay. Such as, and this is no ding on anybody, but Sabrina and I think it was Rodina ran a call with a little old lady, and what was the complaint? I don't even remember now.
Blood sugar.
Okay, but when you got there, what was the actual complaint?
Weakness? No. Just wasn't acting right. She didn't feel good.
She didn't feel good. Guys, I want you to understand that little old ladies, whenever they say they don't feel good, we have an altered LOC, dizziness, weakness, or anything else, even if it's not chest pain, you want to run a 12 lead EKG on them. The reason is because your little old ladies, your little old men, and guys, and I'll just be honest with you, about anybody that complains of these types of things, you probably want to go ahead and run a 12 lead EKG on. Because you have the atypical signs and symptoms of a heart attack, and your little old ladies are the classic people that do it. And a 12 lead might just change your course of action so that your patient doesn't code when you wheel 5 minutes after you wheel her into the ER. Okay? 3, sorry.
3.
I'm not, and like I said, I'm not putting blame on anybody. I just think that maybe, and I'm not saying that a 12 lead EKG would have changed anything. But I'm saying that there wasn't one done until they got to, until they're entering. Did you guys even do one, period? Entering Elk City though, right?
Yep.
Okay. So we just had a 20-minute transport time.
When she told us that she had their chest hurt, we didn't eat it. We did roughly. But yeah, we were 15, 20 minutes into a call by then.
She's you're an intermediate.
Yeah, she was with Sabrina.
Oh, Sabrina was there.
Yeah.
Okay, so we're looking at a lot of.
Yeah, we're looking
Yeah.
at these big difference.
Yeah.
Just
Yeah, we were looking at if we would have seen a STEMI, and I'm not, like I said, I'm not one to throw stones because I make these same freaking mistakes. But we need to learn from them. We need to maybe change how we do business just a little bit from them. Is it going to change anything? I don't know. It might have. Maybe she's seen that she's having a STEMI. She gives her some aspirin. She gives her some nitro. She opens that coronary artery up a little bit. She buys her some time. She makes it to a cath lab, and she had lived to die another day, right? But I don't know. The point of the matter is she did complain of signs and symptoms of atypical signs and symptoms of a heart attack she was having. Chest pain in Elk City, and the 12 lead wasn't done until that point in time, and then she codes 3 minutes after arrival to ER. So
Yeah, I was at the hospital.
So, and I'm, like I said, and if Sabrina, if you watch this, I'm not throwing stones at you. Thank you for the example, but it just we need to do better for our patients out in the country. So what does that do for our basics if we're shooting 12 leads? Because I hear this all the time. Well, what am I going to do on the basic? Yeah, you're going to speed up that time to drug. Okay. Yes, you're delaying a little bit of time. And guys, if you're 10, 15 minutes out, and Sabrina's really good at this is Sabrina, get on the way, and you can do your 12 lead on the way. We're not running, for the most part, diagnostic level 12 lead EKGs that a cardiologist is going to take all that serious, unless you just see the obvious elevation in all the right leads. Those 12 leads, those guys are looking at are crazy, and those guys read crazy things out of them. Ours aren't that precise. That you're not going to be able to get a decent reading out of the EKG. Another thing is if you have one that says acute MI suspected and has a little star beside it, you could then make contact with the hospital. Hey, we have a patient. We just ran a 12 lead. It reads out acute MI suspected. Do you want us to bring him in, or do you want us to get him on Aerivac? And Aerivac has some medications that can help. And I wish there was somebody here, because I don't even know what they're running anymore. But don't discount this hospital either, because they do have the ability to run the thrombolytics. So anyway, any questions there? So tonight I just want to go over the ACA or the protocol 5B. I want you guys to be becoming familiar with the protocols and how to use them. I saw that Aubrey had it on his phone. Bravo, Aubrey. Yeah, guys, those different things you guys are doing, the EMS tab, like Sarah just said, the protocol on your phone. I don't know, is it a standalone, or do you have to actually have internet connection?
You can have internet. I just need it.
Because you got a Crapple. So those people with Android phones, we could actually download it and put it on our phone. So we don't have to wait for it to download, which would be great. We have the protocols on the tablets, so you can pull out a tablet and open it up. I highly encourage you to use it if you get lost on your call. It's like, oh no, can I do this? Can I not do that type thing? Pertains more to my paramedics than really anybody, because your drugs are very limited, right? So what are they, Aubrey? What drugs are you running?
No, that's okay.
He's a...
Yeah, no, he can push it.
So you got albuterol, Atrovent, epinephrine, D50, Narcan. All you guys have Narcan. Everybody has albuterol, Atrovent. Guys, I hate to say this, but if you're not comfortable with the drugs that you're able to run at your level, whenever you're on, take 30 minutes and just look at your drugs. Look at when you could give your drugs. If you need to print out the section 16 of the protocols where the drugs are located and pull out the drug that you're able to give that pertain to you and just highlight your sections and just read those, do it. Guys, the medications that we can give can change the call. So anyway, I'll get off my soapbox. We'll start looking at the actual protocols. My projector's not here, so I'm gonna do this just a little differently. I printed it off for you, but everybody understands that on your protocols you have different sections. Now, depending on what version of PDF you either have a tab over to the side, which has section 1, 2, 3, 4, all the way through 16. There's 16 sections. Each section pertains to a different thing. So the section that we're looking at tonight is non-cardiac arrest chest pain, or section 5. Let me make sure I'm telling you exactly right. Section 5, cardiac non-arrest. And we're just looking at the first 3, A, B, and C. Because I want you guys to kind of see, and part of this is when to do a 12 lead. So does everybody have their things? If you look at your 5A, you have chest pain, uncertain etiology, adult and pediatric. Your general supportive care, obviously, right? So here's your treatment. They even have a little yellow box over there to the side that has your treatment priorities. 3 and 5 minute of patient contact, you should have vital signs, O2 if indicated, EKG rhythm, if paramedic. You know what, guys? I'm going to call bullshit on that. 5 minutes? Come on. That's a lot to do in 5 minutes. You both got to be clicking together. It's a great goal to shoot for, but don't let the times bother you. So, and then 5 to 10 minutes of patient contact, 1 adult aspirin, an IV if I-85 higher, 12 EDKG, adult if ACS per protocol, you're going 5C, and then repeat vital signs. And then you have your flow chart here. And obviously, at your level, you're going to do everything above it. So basics, you're going to advise to avoid physical exertion. And what that means is don't have them walk out of the house and get into the ambulance, especially if you think they're having a heart attack, all right? Now, I'm not saying that you have to pick them up out of their lazy boy chair when they're 350 pounds and put them in the cot, but try to reduce how much physical exertion they have. Adult, avoid aspirin, 324 to 325 milligrams, advise aspirin. And this is for your, the collar. So this is EMR or EMD and EMR protocol in this white here, EMD. So we're going to go down to EMR, EMT. General supportive care, obtain vital signs, O2 via nasal cannula or non-rebreather if dyspnea or pulse ox at or below 94% at room air. I like that they're doing that with the basics and EMRs, that we're not just flooding everybody with oxygen. So you're looking at that 94% level. Apply cardiac monitor, adult obtain 12 EKG. We are equipped, so you need to do that as part of your protocol. To not do it is actually go against the protocol, and it's a protocol violation. And Vicky will chew you out for that.
I'm such a hard guy, you guys.
And I talked to you about something.
Transmit 12 EDK to receiving emergency department. We have the ability to do that. I have probably dropped the ball a little bit by allowing us to kind of slide away from that, but it's something that we need to get back to doing. Then all levels, EMT, EMR, aspirin 324 milligrams chewed by patient. If they take it within 6 hours, then you don't have to do it, but document that on your documentation. Aspirin withheld because patient took it prior to our arrival. All you have to do, okay? But make sure that if you don't give it, you have a reason why you didn't give it. And then assist nitroglycerin self-administration if they have nitro, okay? Now, what are we looking for if we're going to give nitro? Yeah. So what's our blood pressure need to be for us to give nitro? So, above 100, right? 100 above. So, all right, I actually have an advanced and an intermediate in here, so we'll continue on. So, IV access, guys. I've jumped Rodina's ass several times for this, and I'm probably gonna.
It's rubbing off, and I'm fixing to have to whoop your little boy.
And I'm gonna start jumping you for it too, Aubrey. Guys, we need to be practicing IVs more.
Okay, I practiced twice.
Great.
Today.
Good.
Of course, he rolled in without one.
So,
because I was just practicing.
But it's because you have them crappy hub.
No, it's not. It's because I blew up the vein after I was
an inch and 3/4. Who ordered inch and 3/4 freaking IV catheter? Who thought that was a good idea?
I have no idea.
Those things are like this long.
Well, it's not because the 18 was just freaking too big. But I got a 20 in and everything was fine, and all of a sudden went poof.
So
outside the wall.
Anyway, we need to be better at IVs. We don't get a lot of practice out here, a lot of chances to do it. So whenever we do have a patient that fits, my intermediates, advanced, and paramedics, please start an IV. Tyler, I think you don't have any problems shoving IVs in, as far as I've seen.
Pretty much anytime I've gone out, they needed one.
So anyway, guys, please don't shy away from the IV. All right, Aubrey. I know you're new at it.
No, he wants to do it.
Okay. You know what?
He offered to run fluid the other night for me.
I've worked
practice.
at services that if you were a paramedic, which we're a paramedic service, every patient that is being transported by an ambulance, if they needed an ambulance, they needed an IV. I don't subscribe to that. I don't. But
anything after midnight, if you need an ambulance, you need
They
an
need
IV.
an 18 at least.
No.
Yeah, that's
The
kind of
late-
weird.
so
Sign of the day.
Yep. So I'm not I'm not opposed to you doing that because I think you guys need to be practicing the IVs when you get the chance. Okay. Aubrey, I'm glad that you're working at ELP, being a new advanced because you're going to get experience. You're going to get the chances to do them. I don't know your skill level at IVs. I don't know how comfortable you are at it. I'm just using you as a pin cushion because you're a new advanced. So anyway, so start the IVs. Don't. And guys, and here's another thing.
Sabrina never misses.
One thing I get sick of hearing while I'm going over this IV thing is, well, I thought about doing an IV. You know what? If you think that maybe I should have done this, there's probably a pretty good chance that you should have just done it. Okay.
No, that's my fault. Because
And
I asked him if I should have run a 12 lead. You told me if you ask yourself, maybe
I hear. No.
Should I?
Quit drinking
Then
water.
you just stop doing
Lay
it.
down.
And stop thinking it and do it.
The C, I hear it with CPAP. I hear it with not here. Go down. I hear it with I hear it with CPAP. I hear it with IVs. I hear it with medications. Be a little more aggressive. And I'm not saying, Tyler, I'm not saying that they stub their toe, they need fentanyl. But
they need a large bore IV for that crap.
Oh man, that was
It
ridiculous.
it can take 3 tries.
So anyway,
Don't be afraid to keep trying.
if they're hypotensive, try fluid. So anyway, moving on to paramedic, treat any cardiac dysrhythmias. I was reading the protocol today. I've been given the Cardizem without calling for online medical control. So I'll go talk to Dr. Eubanks about that. I'll tell him, hey, I get Cardizem without calling you.
He approved it last year again.
So
I know.
Well,
But anyway, I think that's silly. Anyway,
Did you ever get that solvent?
the solvent.
For that Cardizem.
Oh, the diluent. No, you can just use normal saline, but it's 100 cc's. I need to tomorrow.
No. We put one on the truck, remember?
No, I used another one.
Yeah.
So you need to go get probably. Yeah, see, she has about 3 bags of diluent, so we'll have 2 on the shelf. Anyway, you guys could read the rest of that protocol there. Moving on down, acquiring 12 lead. Okay, so I want you guys to look at the indications for doing a 12 lead EKG. All right. So you have respiratory arrest, dyspnea, uncertain etiology. So I don't know why you're having shortness of breath. All right, so we'll do a 12 lead EKG. Dyspnea, chronic COPD. Dyspnea, congestive heart failure. Dyspnea, apparent life-threatening event. Do you see kind of a thing that they probably should just put friggin' dyspnea there? If they're
In our class, she said, if you have breathing difficulty, you have a 12 lead going on.
if you're having shortness of breath or difficulty breathing or whatever, you need to have a 12 lead EKG done. Okay? So the one Vicky and I ran, I just knew that guy was hyperventilating. I just knew that he had a lot of stress going on in his life because he was complaining of the numbness in his hands and his feet. His legs were wobbly, and he was hyperventilating a little bit, but it started from palpitations. I put him on, and his heart rate is 170. Okay, yeah. So we go ahead and we treat the AFib. So Vic and I shot a 12 lead EKG. We treated the AFib, and we made him feel better. But guys, if they're having shortness of breath, they need a 12 lead EKG to rule out a cardiac issue. Now, 170, that's an easy. Oh, well, we know why he's having shortness of breath here, right? So post-return of spontaneous circulation from cardiac arrest. Chest pain, uncertain etiology. So if we can't pin down that it's a muscle pain, like whenever we touch it, or whenever they move, it hurts worse. I'm not expecting you guys to do 12 leads on that. That's silly. Now, but if you can't pinpoint where that why that chest pain is there, you should do a 12 lead EKG. Acute coronary syndrome. And I'm gonna pull up some ACS signs and symptoms. But I don't think they have them in here. Bradycardia, tachycardia stable, tachycardia unstable, premature ventricular contractions. I wish they would put a number in there because there's people that walk around with PVCs all the time, and I don't think they need a 12 EKG. So, and to say that we need to do a 12 EKG because they have PVCs, if for me to expect that from anybody but Tyler, I'd expect you guys to be able to read EKGs, right? You guys can't read EKG, so how do you know if there's a PVC? Hypertensive emergencies. Yes, please, 12 EKG. Stroke, syncope, poisoning, conductive energy weapon related management. Tyler, don't electrocute people. Less than lethal.
Does that count, taser?
Yes, that is taser. That's exactly what that is. And then lightning electrical injury. Do you guys notice what the contraindication to a 12 EKG is?
None.
None. So if and I've told you guys this before, and I'll kind of say it just like the IVs. If you need practice, which you probably do if you work here, and you could justify in any way to do a 12 EKG, or I guess unless you're up here at the upper apartments with somebody that you're just going to bring them down here because they've been sick for 3 months. Then
That's not fun.
It's a very common occurrence.
But if you're out in the country, we have so many electrodes that need to be used up. Please do 12 EKGs. Practice them. Okay. Get comfortable doing 12 EKGs so that time when you have that chest pain, you're not shaking and crapping your pants because you have to do one. Okay. Become comfortable with that skill. Practice it. All right. Now a 3-year-old that may not need a 12 EKG. But, so here's the steps of acquiring a 12 EKG. They even have the placement. If we need to, we'll do a placement class. How does everybody feel with their placement of 12 EKGs?
On this placement, it looks a little different.
What's that?
This placement looks a little different from what I remembered. I thought B1 and B2 was up here, and B3 and B4 is here, and then 5 and 6.
Nope. You have your limb leads. So you have RA, LA, RA, RL, LA, LL, right arm, right leg, left arm, left leg. Okay, that's your 4 leads. And then you have
Obviously.
your B1, B2, your fourth intercostal space, right? Let me make sure I'm telling you correctly. Yeah, fourth intercostal space. Just to the side of the sternum on each side, and then you're gonna go down an intercostal space. Midclavicular.
And then 4.
That's 4. Split. Yeah, split 2 and 4 with 3. Run on straight out to the side to your mid-axillary line. From V4, place V6, and split that with V5.
But again, it's not dead. I mean, it's not dead nuts. It don't have to be.
No, exactly. Thank you, Tyler. You don't have to have exact placement. It doesn't have to be exact. All right.
All the pec muscle or the breast line.
Lift it up, Aubrey.
Not where it ends, where it starts.
He's saying the breast line, the crease, Aubrey. So if you gotta lift that sucker up and get under there and clean the flamunda out.
You gotta start dating outside of the bingo.
You gotta stop now, son.
So I want you guys to look at their thing. They're showing right-sided 12 EKGs too. You guys, for my paramedic in here, you understand the importance of a 12 right-sided 12 lead if you're gonna administer nitro. Yeah, you can if they have a inferior MI and you give the nitro, you can bottom their pressure out and kill them. So It's an inferior lateral. Lateral.
I think you're right. But I forgot what, I need to watch that Bob page again.
Bob said he'd come out.
I've been Bob twice.
I've been to Bob. You know what, guys? Whenever I went to Bob, I just got into, running around and learning how to. I just got into being an instructor, and I was like, teaching this crap is teaching this crap. It's all boring. It all sucks. Bob Page makes it so much, so interesting and actually entertaining, and that's and so he's fun to watch. Working with Leedy on getting him out here, and then we just kind of went away. But I need to go ahead and pursue it. It's just he's kind of expensive. Get out here. I need a commitment from everybody, so we'd have to do it kind of far out, because I think we're looking at $1,200 a day for him plus expenses. So you're looking
So your right side is exactly like your left side.
Yep.
Exactly.
Yep, just flip it. You don't even move V1 and V2. You just circle your V3, V4, V5, and V6 lead and just write R. And so, anyway, we all know how to acquire a 12 lead EKG, I hope. If not, we will do a 12 lead placement class again for anybody that needs it. More worried about my newer people, like Tyler. I don't know who. No, I'm just kidding. Hey, Caitlin, are you comfortable with the 12 applying?
Okay.
Okay.
We
Because
work together.
okay, so
If one doesn't know how to work together, we
don't be okay. I want you guys to be like, no, I'm solid. Now, guys, I understand. I worked at a busy service. And I was nervous to put 12 EKGs on because it is kind of, you want to make sure you have good placement. It's kind of a little nerve-wracking to do it. And there's all these leads. Once you get it, though, once you get it, it's like, this is easy. Why was I so scared of? So please take the time.
To be scared. You're not going to hurt the
No,
patient.
exactly.
I mean, the worst thing they're going to experience in your 12 lead is pulling the hair off their chest.
The worst thing though is having a room full of people watching you do this. This is the most nerve-wracking part of it.
Yeah.
We're trying.
Oh, man. What is your deal?
This is what it looks.
Why?
So I tried to go to the bathroom and you made me get out of there, Dad. Dang it.
Everybody looking over this way. Well, it must be over here somewhere.
Oh, man.
Meeting
Why'd you let her do that, Greg?
Don't turn around.
She'll leave it, it's okay.
No, she went in there and laid down off the carpet.
She must be sick.
I think that's the end of the meeting,
Maybe
dude.
she needs a 12 lead.
No, I think that's the end of the
Maybe
meeting.
practice.
He's gonna need.
Just do that and then spray out that orange stuff and I'll get it afterwards. I don't even get it. There's some orange disinfectant spray in there. We go get it and just spray out the towel so Lindy doesn't die. And I think Greg's at home with it.
I didn't think Lindy could smell, so I think we're good.
I can't hear.
Oh.
Wrong sentence.
And it's colorblind. It's colorblind.
It's green now, isn't it? No.
Got to make
No, it's not green yet.
I got to make Tyler a little nervous in my colorblind.
Yeah.
Isn't that fun? Tyler's kind of easy to poke at right now, though.
Yeah.
Eventually, he'll figure out that, that we're just sort of making fun of him. But for now, he just does the fun.
Pulling up AHA's ACX. So anyway. dog kind of killed the meeting. So,
Yeah.
any comments on any of that we talked about? Any suggestions? Any no?
My thing is, even if you're uncertain about it, I go ahead and do it. It's better to play on that side than the other way, right? It's not gonna hurt anything. No.
Since you're all here, and we kind of went over this a little last time, not a whole lot of people here. We've been redoing the supplies. Does anybody see a pattern here to the supplies? Anybody see kind of how they're laid out?
They're all in my boxes. Airway.
Yeah, IV, airway, bandaging. I understand there's a few things that kind of cross over. You have some monitor supplies over here, but then over here on the airway is where I have the disposable pulse ox probes and the nasal cannula entitled CO2 probe. Guys, boys in this. The idea behind this is that anything that's on an ambulance will have a spot here. Now, whether it's on the shelf or not is another story. And there'll be there's some of them that say 0, like our laryngoscope blades. I'm not keeping spare laryngoscope blades unless we have them. I'm not going to order a spare. So the idea is to get some high visibility magnetic things that say the unit number. So it'll be like an orange magnet that says 24, and there'll be 10 of them. 10 22s, 10 20s, and 10 21s. And so whenever you come to stock your ambulance, like we do our monthly check, because that's where we're going with it, and the ambulances are going to be labeled. They're going to be relabeled. Though they will have everything that's on this shelf. So you go to stock your ambulance, and let's say that you are missing a surgical airway kit. Well, I'm not planning on keeping any surgical airway kits because I'm hoping, or chances are, the surgical airway kits will date out before we ever use it. And so I'm not keeping the next one on the shelf. But if you do use one, you run that call that you use a surgical airway kit, you come in, you're like, oh, there's none there. And it's on 24. You grab a unit 24 sticker or magnet, place in the surgical airway kit. And that way we know that we need to order a surgical airway kit for unit 24. Okay. And then once it comes in, we'll take it, we'll take the sticker off, we'll put it in, either put it on unit 24, or if it's, for unit 20, we'll create Lindy a little box or something like that. For him to put on the thing. I talked about it last month. Once I get this done, I want us checking the ambulance. If let's say that you're putting in 4 shifts a month, I want you checking it, doing the monthly check. One of your shifts out of that month. Okay, takes a long time to do. It sucks. I did it on 2 of the units already. Takes a little bit of time to do. But hopefully we get to where we're not finding gobs of items that are expired, okay? It'll help us maintain the trucks. The trucks are not Rodina, Vicky, and my sole responsibility, okay? It's all of our responsibility. It's everybody's responsibility to take care of the trucks, check them, make sure that the equipment's in date, everything else. It is, however, going to be Rodina's responsibility because she's the main supply person. Vicky's my QA person, if you guys haven't noticed, is to make sure that the numbers that are supposed to be here are here. Now, understand we're going through some things right now. We're trying to get it situated. And so it's going to take a little tweaking. But I need your guys' help. If you do find something that's on the ambulance that we don't have a place for on the shelf, or vice versa, let me know so we could either get it on one or the other. Or if you're checking, you're doing your ambulance check and you realize that, hey, we don't have XYZ on our list. It needs to be on the list because we need to be checking it at least once a month, okay?
Or if you come in to resupply your ambulance after a run and you don't have something to resupply it, let someone know. Not you.
Sleep a note on the ground.
Well, that's what
Tell me the soft scares are on.
that's what the magnets will be for. So the magnet will, that way you don't have to leave a note and it gets lost, because I'll tell you what, I'm the world's worst. You guys leave me notes. It's like, I see it, I mean to take care of it, and I get busy doing something else and it gets under a piece of paper and I don't see it for a week. And then I forget about it. I'm the world's worst at it, I'll admit it. But if we have a magnet that's up there and it's up there until we order it, and then we don't move that magnet until it's back on the truck, that will help out a lot. And so that's the idea behind it, to eliminate a lot of the redundant communication. Where if one day Caitlin comes in and she sees that she doesn't have XYZ, and she comes in, she's like, oh, it's XYZ's marked here. They've ordered it. And so she knows she doesn't have to, keep telling them. So that's the idea behind it, guys. And it's going to be a work in progress too. Everything I'm doing is a freaking work in progress. Job security. You hear that, Rodina? Job security. So anyway.
Give me some of that. Just gotta find a job first.
I'm still working on it. Still labeling. I almost have the shelves labeled. And then I'm going to start working on the units. And I'm probably going to start with like 22 first, because each time I notice I tweak something different. Like, whenever I first started it, I was doing a pediatric and an adult kit. Well, the state requires you to have 2 sets of everything from adult to pediatric on your advanced airway stuff. So why would I separate them out? Why not just have 2 complete kits? So no matter which kit you grab, you have everything you need. And so it's been a change. With that being said, there's going to be numbers here that we're going to try to maintain. Now, right now, I know that there's some things that are out and there's some things that are low. I know that. I've told her not to do big orders yet because we're still trying to build it. Now, there are some things that do need to be ordered. But on the trucks, though, guys, I want it to where you guys aren't overstocking freaking trucks. I don't need 60 nasal cannulas. Okay, if it says 3, have 3 on there. Whenever you go do your check, if you notice that there's 5, pull those 2 off. Now, if you guys notice that, hey, I'd really be more comfortable if we had 18-gauge IV catheters versus 6. Talk to me. Okay, just let me know. And most
Where do you
likely,
get the number 6?
it's a requirement from the state.
Is that total on the truck or?
Yes.
Yeah.
So between the back, the
I
IV
really thought
bag
it was
and the
5.
wall?
Yeah, no, it's total on the truck. So anyway, 5, 6, I don't really give a shit. One way or the other, if you're more comfortable with 8 and the thing says 6, let me know so we could change that. Okay, so change the levels so we're not always pulling off and you're always putting it back on. Okay, I know that there's some things that Sabrina wanted to do. And everything's gonna have a home. It kind of goes with this too. I want stuff to stay in its home. And whenever we put the glucometer in, whenever we decided to change the glucometer to the EKG, put it in the EKG monitor, I want it staying there unless we change that. If it becomes, it's like, this is stupid, and most of the people want it off there, we don't care what Arivac does and Sabrina, we'll do it. But it's, the dialogue or discussion needs to happen. We need to decide it. I'll send an email saying, the things need to go back in their home. So that way, and guys, remember, we're a low call volume service. It's hard to become real comfortable with everything is. And if we keep moving it, you're not going to be comfortable with where it is. All right. You're just going to be like, shit, it's not there. And you're going to freak out. You're going to start throwing everything everywhere. I've seen the ambulance after you guys do that. I've seen the ambulance after I do that. And I'm trying to prevent that. I'm trying to make it a more relaxed, easy environment to work in, as much so as I can on an ambulance. And so if we have things in their home, you are pretty certain that if you go to this cabinet that you're gonna find your oral glucose in there. You're not gonna freak out. You're like, you might just, oh, okay, and it's behind the dextrose, and grab it.
And also, if you do the monthly thing, even though it is a pain in the butt, that is, especially for the new ones, a way to learn where everything is, where you know where everything is and you get comfortable with it.
Yes, and that's one thing that drove this. Thank you, Vicki. Was the people coming in and saying, well, I couldn't find this. Well, I couldn't find that. And it's like, and then I go and where I put it, where I had it on the ambulance, where it's been for a long time, and it's there. And my thought process on that is, I really don't feel sorry for you because you don't know where the stuff is on the ambulance that you're working on. That is your responsibility to know that. It's not my responsibility to do an in-service on where every piece of equipment is. Even though in-services are nice. We need to talk about things. But once we get the ambulances set, I want them set. Make sense? Any objections? There is, shut up. All right. No, I'm just kidding.
You don't want to be in the middle of doing whatever you're trying to find to get familiar with that, or it's going to be this could be a more relaxing time.
I found things on the ambulances such as 3 glucometers on an ambulance because they're just whenever I first came here, it was really bad. There was a whole bunch of 4x4s in this cabinet, and a whole bunch of 4x4s in this cabinet, and a whole bunch of 4x4s in this cabinet. You can tell the people really like using 4x4s.
We've got double 4x4s.
For everything.
Yeah, it's great. But the thing is what it was is somebody liked it here, somebody else liked it here, and somebody else liked it here, and that's what happened. And then the ambulance become hard to work out of, hard to find stuff in, and whenever you do pull something out, everything goes everywhere. And I want to eliminate a lot of that, and actually I want to get down to where we reduce kind of down to a minimalist view on the ambulance, because it makes it easier to work out of and easier to find things. But anyway, I'm done with it. I'm done with the meeting. I got dog vomit to clean up, I guess. Anything that you guys seen throughout the month? Anything that you guys want to say, hey, good job to somebody? I did say good job to Vera and Jimmy, even though that there were some things I think they could have done different. They did get a code save, which is great. I'm happy whenever things turn out good, so I want to give them kind of a good job. I think you guys do a great job. Don't let my monthly complaining deter you from doing a good job, because I think everyone does a great job and tries to do a good job. So,
For our small service, but not a whole lot of I got to go when I was working, get my clinicals, and the sign people goes, we work Sarah now. And I said, we hate working Sarah. And I said, why? And he said, because it's either everything or nothing. I said, welcome to our world.
Yeah.
That's how it is.
Go tell Vicky. Go tell Vicky. Or Sarah.
It is. That's
Sarah, she wants out.
you need to go outside.
She wants out. Okay. Okay.
So, anything else? I'm done. I'll stop the broadcast and then you guys can talk.
Um,